Hey guys, this is Dr. Izrab with Integrative Kidney Solutions, and today I'm going to be talking to you about SGLT2 inhibitors and their use for progressive diabetic kidney disease. We waited for a while to come up with any new videos in this series, and the reason really for our wait mainly was because we submitted the letter to the editor to the New England Journal of Medicine after the Credence trial came out, and unfortunately it took a long time for this letter to the editor to hear about it and then to hear that it's going to be published and accepted. So today is actually this letter was published, and we are free to share with you the information that we want to share. We talk about diabetic kidney disease. Since the 90s, actually, pharmaceutical companies and nephrologists have not been able to come up with anything new since the discovery that ACE inhibitors and ARBs can slow down the progression of chronic kidney disease. Meanwhile, the prevalence of type 2 diabetes is skyrocketing, mainly because the population at large is eating junk food, probably. But now the pharmaceutical industry is trying to convince us that newer medications such as SGLT2 inhibitors are good to slow down the progression of kidney disease. So now that we have full understanding of what's going on, I want to explain to you that there are some data that shows that those medications can have improvement in outcome and cardiovascular outcome and renal outcomes in patients with diabetic kidney disease and diabetes in general. But what I want to really make you aware of that a few precautions that you really must take when you think about prescribing these medications for your patient with type 2 diabetes and diabetic kidney disease. First of all, I want to make sure that you realize that in Credence, the canagliflozin group only was given only 100 milligram daily of canagliflozin. So make sure you do not increase the dose on these medications, and if you want to try to use these medications, make sure you use small dose. And also remember that Credence trial also looked at only patient with stage 3 and above. So the patient in the treatment group had a GFR of more than 30. So don't use them for patient with advanced kidney disease. At least so far we don't know that you can use them with patient with advanced kidney disease. There are data actually in the package insert of these medications that these patients can cause acute kidney injury and dehydration. So that takes us to the second point. And the second point is that these medications are actually, they have diuretic properties. In fact, SGLT2 transporters is very common and present abundantly in proximal tubular cells. It actually works like a gatekeeper that help with reabsorption of sodium and glucose from the proximal tubules. So basically, actually, the name SGLT means sodium glucose cotransporters 2. So when you give your patient these medications, they're going to have more glycosuria and natriuresis, so they're more likely to develop dehydration than a patient who did not receive these medications. So if your patient is receiving a diuretic, especially loop diuretic, maybe you should be aware and be very super cautious about using this medication, probably not using these medications. I do think, though, that these medications may have a role in use with patients who are wet, who have mild volume overload, who do not have diabetic wounds or diabetic ulcers. And that takes us to the third point. The third point is that in the Credence trial, the investigators did not find that canagliflozin increase the risk of limb ischemia or limb loss or amputations. And the reason for that is that because they selected their patient very well, and they had the robust monitoring program to make sure that any patient who have any diabetic wound or ulcer to be excluded from the trial. So be careful when you use these medications. Make sure that you do not use them for any patients who have diabetic foot or diabetic wound or diabetic ulcer. Also remember that these medications can also cause Fournier syndrome. And the fourth point that I want to emphasize to you is that blood sugar control and diabetes control remain the mainstay treatment for diabetic kidney disease, and optimizing diabetes and blood pressure control are super important. In fact, in the Credence trial, the placebo group had worse blood pressure and diabetes control than the treatment group. So if the investigator were very diligent and tried to control diabetes and blood pressure in the placebo group, as well as they treated the treatment group or the canagliflozin group, they could have probably found no difference in outcome between the two groups. And now we get to the final point, and the final point is that we still don't know what the effect these medications have on nutrients. It is probably possible that these medications can lead to loss of nutrients. They do block the absorption of sodium and glucose in the tubules, so they can lead to glucose loss in the urine and osmotic diuresis. So it is possible that they can also lead to loss of other nutrients. We still don't know that for sure. For more information, follow us on www.inkidney.com. You can also find us on Instagram at Integrative Kidney. You can find us on Facebook and Twitter. Please, if you like this video, press the like button, and don't hesitate to comment. We'll be happy to hear from you, and have a great day.